cardiac or congestive heart failure, a wide variety of cancers were analyzed. People that were put into hospice actually lived 29 days longer than people who were not put into hospice. I think that's fascinating. A clinically tested, controlled set of circumstances, half not in hospice, half in hospice, the hospice patients actually live longer. Why is that? It's because when you reduce pain, when you reduce suffering, when you are clear-headed, you have an opportunity to bring things to closure in a more peaceful way. There is more of a reason to move forward and live than there may have been previously when there's so much suffering. So I thought that was kind of fascinating. We touched upon this earlier. Most people want to die at home. They don't want to prolong unnecessary therapies. Knowing that my family can give support to my mom or my dad is great, but it's also important to the patients that they know that the families are being taken care of. I can't stress that enough, that most patients are more worried about the people that they're leaving behind than they are about themselves. And so this is pretty factual. And what we know about death in a hospital is that, what I've discussed earlier, it can be pretty brutal. It can be hard on the patients, worse on the families, not an appropriate setting for bereavement. Death in the hospital sometimes is inevitable, but it is not the best environment by anybody's set of circumstances. A lot of people believe, another myth about hospice is that hospice is always palliative, because palliative is comfort. Giving palliative care is comfort, but not all palliative care is hospice. Does that make sense? All hospice care is palliative. Not all palliative care is hospice. So you'll see, you'll hear, you'll be in clinics, we do palliative care. Everybody should do palliative care, but hospice is a discipline that's unique, it's individualized, it's special, and we are expert in helping people transition from life to death. Absolutely expert, and we know from working with individuals over 30 years how to design plans of care and unique ways in which to best serve these families. Sometimes it's pet therapy, sometimes it's art, sometimes it's massage, sometimes it's just leave me alone. Sometimes I need to speak to a chaplain. Other times is I'd like to see my daughter get married, if that's the last thing I do, and then I'm ready to go. Sometimes you have do not resuscitate. Sometimes you still have chemotherapy. And I'm going to give you an interesting example. Can I still get chemotherapy, aggressive treatment, and be on hospice? Typically not, but if it reduces pain and suffering, let's say I've got a tumor, and my tumor is pressing on an organ, and I am in great amount of pain. Chemotherapy might be ordered and approved to reduce that size of that tumor to take away pain and suffering. So you're treating the pain and suffering piece of it. So do not be misled by it's black or white, it's yes or no, it's either or. It's not. It is absolutely based on patient needs and individual plans of care. The old model of healthcare is hey, I've got a serious illness, I'm terminal, and I'm going to start working, or I've got a serious illness and I've got these life-limiting issues, but I'm going to try to prolong my life as long as possible. If I heard bad news today about myself, I'm going to want to fight like hell. Excuse my language, but that's my goal. And I guarantee you, at this point, I would do everything I could to continue to live as long as possible. The old model basically said, hey, you fight as long as you can and as hard as you can, and then there's nothing more we can do, and then we die. That's the old model. The new model is much more realistic, and it's doable, and it's being done all over the country. Whether it's Tidewell, it's Hope, Healthcare, it's Boca, Grande Clinic, we're looking at people that have serious illnesses, and okay, I'm doing my aggressive treatment, but I'm also getting palliative care as a part of that process. So that box now is divided into two. Aggressive, but yet palliative to reduce some of the suffering and some of the pain. And then hospice is brought in ideally much earlier so that we have time to start working on all the other issues to bring people to end of life in a very logical and in a very peaceful and in a quality way. And then you see bereavement, because that is a piece that has been missing and still missing in so many set of situations. This slide was shared with me at a conference a couple of weeks ago. Doctor talking to a patient. No easy way I can tell you this, so I'm sending you to somebody who can. And it's interesting, many doctors refer late because they have connected with you. They love you. They've known you for 10, 15, 20 years. Dr. Mike here might have a tough time saying, Rosemary, we got to start considering some options. That's where the partnership and collaboration comes in. We're working on something right now with one of the cancer specialists where our palliative and our end-of-life doctors or nurses are staged in the clinics and in the offices with the cancer specialist to start having that conversation, because he's charged with saving and I'm charged with transitioning. That makes a lot of sense to me. And if Rosemary knows we're both in this together and we're collaborating and we understand each other's motivations and we have her best interests in mind, guess what? It works. When you have people that are not talking to one another, it just simply does not. I'm going to go through this quickly. When you have Medicare, when you have hospice benefit, you get a nurse, you get a doctor, you get a clinician, you get therapists. You can have speech, occupational, physical therapy if it's related to relieving pain and suffering. The net of it is that all the therapies, the massage, the pet, the art, the music, they're all available to you. Not every patient has all of those, but you can. But typically you're going to have the ones that are most meaningful. And in addition to hospice, list of things here, all your needs as it relates to drugs, biological, durable medical equipment, tests that are ordered, any kind of therapies that are deemed appropriate are also 100% covered under the Medicare benefit. As I mentioned earlier, if you poll people, they say 9 out of 10 say they would prefer to die in their own homes. So this is probably the most important part today, because people think of hospice as, I go to the hospice house and die. No, you don't. You can. But a hospice house is really intended for acute symptom management that would be comparable to what you would get in a hospital. Your symptoms have become not controllable at home. You go to a hospice house. You do not go to a hospice house to die. The goal is a hospice house is really intended for a treatment of acute symptoms. So in that you do not have a hospice with hope that's geographically convenient to you. Our nearest one is Cape Coral. Those of you who have been there and have had friends and family there, you know you get the good treatment and you get the services and you get the compassion that you desire. But it's not convenient. Tidewell is more convenient. Let me tell you right now, if you need to be in a hospice house, we will facilitate that for you. No problems, no issues. It's not because we're good people. It's because, honestly, it's legislated. This is, you can choose wherever you want to die. This is your choice. This is not my choice. So if the best set of circumstances for you to be is our house or the Tidewell house or in your home, that is what we're going to work toward, is your needs, not what Hope's needs are, not what Tidewell's needs are. So if you need to go somewhere outside of our scope of services, it is our job to facilitate that for you. Respite care. Oh, let's back up to home care. 85% of all hospice in the United States is delivered in people's homes. 85%. You can be eligible for hospice within 6 months of end of life. We could be in your home with a plan of care that was unique and specialized to you, your loved one, your family, over the course of 6 months. Sometimes people get better when they're on hospice, and they graduate out. And why? Because they're not in pain anymore. We've alleviated symptoms. They've been able to relax. It's an interesting, I'm not trying to encourage you to go to hospice, you'll get better. That would be inappropriate. But what I will tell you is that people do leave hospice. And then you might become hospice appropriate again in a few months, a few days, or a few years. You can have hospice unlimited number of times. The qualification for hospice, as I was discussing with this nice couple here a little bit earlier, is you have to be certified by a physician every few months that you're still hospice appropriate. But you could be hospice appropriate multiple times. And you can have hospice in your home. And hopefully, and if we do it right, we can let you die at home if that is your wish. The next level is that you're a hospice patient, you're transitioning, you're in a position now where your niece is getting married in Chicago and the family would like to go. The reality is a hospice patient can come to Tidewell or come to Hope Healthcare, one of our houses, and be there for several days because you know we're going to take good care of mom or dad or whoever is your loved one, and you can go do things to keep on living your life. And believe it or not, that makes those patients really happy, knowing that you're not a burden, that they're not a burden to you, that you can use the respite within the hospice benefit to put patients there for a period of time so that you can do other things and keep going on with your life. Does that make sense? So respite care is respite for the caregivers, and the hospice patient goes to a house for management for several days of service. I'm going to go back on that one. Inpatient. As I mentioned earlier, inpatient care for hospice is typically going to have, at least in our area, in the hospice houses. That inpatient is for acute symptom management. The last one I want to talk about is continuous care, and John brought it up in the introduction. If we do it right, we know you. We collaborate with Boca Grande Clinic. There's no reason why you can't have that acute care in your own homes. With proper telehealth monitoring, basically, we're seeing your symptoms live 24/7 all the time. We collaborate with clinical staff that are properly trained. We use our staff. We use Boca Grande staff. We are in a position where we get the right person for the right patient in the right need at the right time. Sometimes that's a social worker. Sometimes that's a chaplain. Sometimes it's just going to be a doctor. But we can provide continuous care in your homes, and it is a wonderful thing where you never had to go to a hospice house. And so even though going to hospice house may be preferable, I believe it is, than going to a hospital, the goal would be if you want to die at home, we're going to do everything we can to make sure that that happens. And this is something that most people don't know exists, and it's not unique to Hope, but it is something that people aren't very familiar that we have. And this is some of the conditions that for our continuous care. Your period of crisis, their acute symptoms, all the things that would take you to a house or a hospital, but the patient wants to stay home. You do have intensive nursing care available to you. It's a minimum of 8 hours a day, and it's got to be greater than 51% of it has to be by a nurse. Hospice should be, your end of life should be more like this, or more like this, or more like this. All of these are our patients, or were our patients, and we have permission by their families to use all of those photos. This particular one, this woman, she was terminally ill. She only had a few days, and she wanted to see her daughter get married, and we were able to accommodate that. And you take a look on the daughter's face and on the mother's face, and I think that pretty well says it all. This particular woman, I believe she is around 101. It was a birthday. We had a little party. I mean, look at the joy going on there. And this isn't easy work, but it's the most gratifying thing I've ever done. After spending 30 years in technology, doing entrepreneurial things, running my own business, I can't tell you how passionate and how much I love this, because you see you can make a difference every single day of your life in helping people navigate through this. You are blessed to live and work in a community that cares about you. And we are blessed and lucky to work with people like you, the Boca Grande Clinic, in order to try to help facilitate things here. We don't care about quotas. We don't care about census. We care about quality of care. We care about unique care plans. And we care about doing what you want to do at the end of life. So with that in mind, I think I'm going to overstay my welcome, and it's probably appropriate that I open it up now for some Q&A. So anybody have some questions? Oh, before I do, I want to introduce Michael. Please come up here, Michael. Michael Tobiasen is very, very expert. He is a registered nurse. He is old enough to have some valuable experience in the healthcare industry, but he's young enough to still have a whole lot of gas in his tank. And even though he is highly recruited, I know this all the time, to go in many places, anything from the practice administrator at skilled nursing facilities to going back up to New York in his hometown and doing work there. He chooses to do what he does every day because he truly is a caregiver. And so if I'm the business side and I'm doing the proselytizing about end of life, quality of life, and hospice, Michael's would be my counterpart as it relates to the clinical side and actually facilitating those clinical needs. So I've asked Michael to come up so that he could help me answer questions. You want to turn on your mic over there? I'm going to turn mine off, and we'll just share that.
Anybody have any questions?
Where are your headquarters?
In Fort Myers, where Health Park Hospital is. It's in South Fort Myers, closer to the beach, Fort Myers Beach. That's where our headquarters is, and we have a hospice house there. Sure.
Some of us are in Charlotte County, the north side of Seattle. Are we eligible also, or is it just Lee County?
Lee County, correct.
But we'll work with you and we'll work with Iowa too.
Uh, Absolutely. There's a process that hospices can go through to transfer patients, so there's a continuous care. There's no gap in your care, and we can help with that.
Many of us here live in two places, and I think you just touched on it. But say we don't want to spend summer here, can it be transferred to
Absolutely.
Maine, Illinois?
Absolutely. There's a process for that. There's two. That we can transfer you. There's something called a change in designated hospice. There's process behind that. And it's not as difficult as it's made to sound to be. But we...
Tell me about the Sanibel patient that came to Dallas Beach. Do you know that?
I am. He came from Connecticut.
Yeah.
We had a patient who, he was relatively young, I believe. I believe he was in his 50s or 60s, and he was dying. And his last wish was to, I guess where the family summered was in Sanibel Island, and that's where he wanted to die. And I believe he had a sister that lived in the area. So we were able to facilitate a transfer for him to come from Connecticut down to Sanibel, and and he passed away on Sanibel Island. And that was his wish. Sure. Absolutely. Sure. Well, hospice is a Medicare benefit. So, and anything related to that terminal diagnosis is paid for through that Medicare benefit. I can get into some of the technicalities behind that. You know, hospice is broken up into what we call benefit periods. To be admitted into hospice care and meet the Medicare guidelines, there's based on your diagnosis, there's certain clinical data that we need to gather to be able to say this patient is, and I don't like to use this term, and I avoid it as much as possible, But when you ask a question like that, I have to say hospice appropriate. I don't like to say that, but that's the reality of it, is a physician has to say 6 months or less to live if your hospice, if your disease runs its normal course. You know, I'm not prepared with any data as far as what the average cost is for the care of a hospice patient. And again, it all depends on your diagnosis.
Are there out-of-pocket costs or anything?
It's 100% covered. And it's broken, like I said, into benefit periods. So your first 180 days, every 90 days, we have to look at how you're doing and so on and so forth. But if you choose to enhance your hospice care, like we have patients that are on hospice, and we do supply a home health aide and a homemaker, you know, certainly the core group, the nurse, the social worker, the physician. There are some patients that choose to have extra help, and that would be an out-of-pocket. You know, somebody to be there 24 hours a day, extra aid care, things like that. There's an out-of-pocket cost. But hospice and anything related to the palliation, the care of that, of your illness is covered by Medicare. And then private insurance is also, most private insurances follow along with the Medicare guidelines for that. So. Right.
They were wonderful. They sent an aide, they sent social workers, they sent a nurse after from the field. It was really nice. But I had to cover the rest of the care. And that's what people don't understand, is how hospice can expect 24 hours a day care. That's not exactly the way it works. So I took a shift and I paid help for it.
Right, and we can.
And I got one at home.
And we can help with those resources. Yeah.
But I think when people do not follow hospice soon enough, you know, for the past 20 years, this is what I've seen. They think that it's saying you're going to die right away. They don't understand. And I'm so glad you're here.
Thank you.
Absolutely. That's the number one myth with hospice, and we find that every day. You know, and it breaks our heart when we find out that we have patients that die in the hospital, in the skilled nursing facilities, without having hospice there. You know, Samira Beckwith, our CEO, she's very concerned when a patient dies not on hospice. As Carol said, not because of our census, not because of our goals, but because that's somebody that wasn't getting that level of care. And the biggest reason is because people think, well, if I sign up for hospice, that means I have a death sentence. What it means, we do. We provide care in the hospitals. In an inpatient setting, we can provide care in the hospital. We can provide care in a skilled nursing facility, in a nursing home. We can provide care in assisted living facilities. There's a lot of opportunity for hospice, and it's really, it's the whole spirit behind it. It's not just the patient, it's the family, it's everybody around the patient. Nobody should die in pain, nobody should die uncomfortable, and nobody should die alone. And that is actually Samira's and our vision, is that nobody is alone through any type of tragedy like this. So. Sure.
Yes, the term pain management. Do you have the ability to describe as patient dreary?
We do. We have hospice physicians. So we have teams, and each team has a physician. And as long as it's, we have to get into the technicality of being related to the terminal diagnosis, but we absolutely, when you join hospice, you have the right to choose who your physician is that attends to your hospice care, that attends to the treatment of your terminal illness. We can offer you our physicians, and of course we prefer for that to be, but our physician is always in collaboration with your attending physician in the community. And we do provide orders, and we do provide prescriptions and medications to those patients.
Will hospice come to the island, to a person's home?
Absolutely, and we have. At this time, our team that's assigned to Boca Grande does not have any patients right now, but we do, absolutely. We make home visits, and a physician would come and visit as well.
Can you administer both oxygen maybe, end of life, and also pain management or drip or whatever?
We do. We supply oxygen. We have a company that we partner with that can supply oxygen. We also we have a number of different types of ways of administering pain medication, not through the mouth. We have subcutaneous, which is less invasive than a morphine drip, so to speak. But we do subcutaneous infusion right underneath the skin. We like that because it's not as invasive, it's not as painful, and it's easy for us, if there was an issue with the one site, to change it over to another site. And our nurses are trained thoroughly in that process. You're welcome. Did that answer am I answering everybody's questions? Okay. Rosemary had a question.
I think my question is, since there was a pervasive misunderstanding in this community, which said essentially, if you live in Lee County and you need in-house service, you've got to go to Cape Coral. And I think it's going to be really important for the people who are here to convey back to people that they know that indeed is a misunderstanding.
Absolutely.
And that Lee County would provide the services while you're in your home and then assist in facilitating if one wished to go to Tidewell rather than to Cape Coral.
Absolutely. Our goal is to make sure you're taken care of, to make sure that your symptoms are managed and your needs are met. And we can absolutely facilitate that. Hospice is what is your goal of care? You know, as a patient, as a family, if you want to die at home, we'll do everything we can to meet that need. And if we need to partner with another organization to meet those needs, we can do it. It's no problem. And we will do it. So I'm going to move this because I'm getting a sunburn.
I'm going to add one thing too.
Sure.
Yeah.
Oh, sure.
I just wanted to comment as far as like from a general internist or a physician here at Boca Grande Health Clinic, you know, when we use hospice. And I think an analogy that everybody could understand, if you were having a heart attack, what would I do? I would send y'all to a cardiologist. Hospice physicians do a better job at the end of life than your general physician. I'll be the first to tell you, hospice does a fantastic job with caring for pain, doing morphine drips. So when I start to see someone that I think hospice would do a better job, if it looks like it's within that 6-month time period, then I'll definitely start to try to have conversations with hospice. But I almost consider them like a specialist, and that's when I would get hospice involved. And yeah, y'all didn't have to sit down. I just wanted to kind of add that. So yeah. No. Question for me is when I come.
Would you explain the term you used a few minutes ago when you joined hospice in the line of thought, and how it connects with a question from the rear of the auditorium about what happens if I go north, and you said it was transferable. I'm confused by when you joined and transferable when I thought this was a national Medicare benefit.
It's a national Medicare benefit, but there's different hospice organizations. There's different organizations that are licensed with Medicare to provide hospice care. So I'm from New York City, so I'll give an example. So, and we do have a lot of patients that do this. If I live in New York, and unfortunately have a terminal diagnosis, and during the winter I don't want to stay in New York, I want to come to Florida, there's a communication that occurs behind the scenes before that. And there's a discharge plan that your current hospice formulates. So my New York City hospice would contact, I would let them know where I'm going. They would contact Hope Hospice. We would ask for your records and your plan of care. So we